describe for us what interventional radiology is and how it's being used in medicine today?
I tell patients that the arteries are really a roadway in the body to get to any destination. We access either through the wrist or the groin, and we take the road that goes to the liver. Once we're in the liver, we take a series of images to really target and take the roadway or the artery that leads to cancer, and then inject a variety of substances into that area to treat that tumor.
And from what I understand, interventional radiology is a real team-based approach. Can you talk about this approach to care? I know you both work together, and how working together can really advance medical care.
It really started about 10 years ago when Dr. Schwartz, who's in charge of our liver surgery program and works in the Department of Liver Transplant, really invited us to come up to what we would call joint office hours, where patients have really a one-stop shop. They don't have to see their liver doctor, medicine doctor, their surgeon, their transplant team, and interventional radiologists all on different dates, but they really see them in one setting. And patients love it because they feel that they're getting the best care. And so all of us working together really provide the best care, and also it's very convenient. Some patients come from even an hour or two away, sometimes international patients or patients across the country. And so they see everybody in one, kind of like a one-stop shop. And credit to Dr. Schwartz for really envisioning that and working together with us.
Dr. Schwartz, can you talk a little bit about why you started that? What was it that wanted you to reach out to interventional radiologists and bring the team together to help patient outcomes?
There are many people for whom, based on the condition of the liver, surgery is just not possible, other than maybe a liver transplant. And a liver transplant is not something you can just put on the schedule and do next week. You have to sit and wait. And so that we have many people with tumors that are limited to the liver, but yet that cannot be removed. I think there's been a transition in the nature of interventional radiology from a procedure-based specialty to a clinical specialty.
And now are you using IR to treat these tumors? Is it a bridge to, say, a transplant? Can you talk a little bit about how you both are working with interventional radiology here?
It's used in a variety of situations. There are some people with small tumors and good liver function who can have a treatment by Dr. Kim, microwave ablation, or maybe one of the arterial treatments he can go into detail. And that's all they need. And it's a potentially curative treatment, and they can go on for years without anything else being done. The people who need liver transplants because their livers are in bad shape and have cancer, we use it as a bridge to transplantation. And also in people with more advanced tumors that can't be transplanted, we can often do a lot to prolong survival using the treatments that Dr. Kim can do.
Dr. Kim, what, in your opinion, is the best way for specialists to confer with interventional radiologists?
I think it first comes with just a phone call, speaking with your referring physician as an interventional radiologist, practicing, as Dr. Schwartz was saying, clinical medicine, following up with your patients and seeing them beforehand, and then communicating that obviously with the patient, but also with the referring physician. And then there are other avenues such as multidisciplinary tumor boards, where cases are discussed with a variety of subspecialties to really pinpoint the best point of care for patients.
And certainly in larger centers where significant numbers of people with these problems come, the concept of an interdisciplinary tumor board has become basically the standard. That's what you have to do. And every patient seen at our center, whether it's seen first by Dr. Kim or by me or an oncologist or a liver medicine doctor, are all presented. They're all funneled into the tumor board where everybody is there at the table. The pictures are reviewed by the imaging radiologists. The discussion of each potential treatment is put forth, and the decision is made. Records are kept. Patients are notified. It's a very formal process, and I think it's the best way.
And now I'd love to talk a little bit about how these collaborations are really pushing medicine forward in terms of research and just advances in care. Can you talk a little bit about that?
With the developments in technology, that have really been brought forward through the interventional radiology group. There's been a transition from surgery to non-surgical treatment, and there are many patients these days who are treated with procedures in radiology without surgery who 5-10 years ago would have been taken for surgery instead. And I think this is a natural progression. It's happening in many specialties where technology-based approaches are replacing surgery. If we can have a patient come in and have a procedure and go home the same day and have their tumor destroyed, as opposed to coming in for 5 days to have an operation, it's hard to argue against that.
And as Dr. Schwartz was mentioning, we've also looked into gaining entry earlier in the stage of cancer, in liver cancer, with interventional radiology therapies to provide hopefully a curative therapy with better recovery and minimal impact on quality of life.